In this lecture, Heart Failure 2, we're going to talk about an acute exacerbation of congestive heart failure. I'm going to assume you've watched Heart Failure 1 and understand the pathophysiologic concepts behind it. I'm going to go quickly through this lecture, so if you haven't watched CHF 1, go back to 1, rewatch it, understand the concepts so that you can follow along in this one. We're going to talk about what you do in acute exacerbation, that is someone who needs to be hospitalized for heart failure. Let's start off by comparing the system of a normal heart versus a failing heart. A normal heart has good forward flow. It is not dilated, and because there's good forward flow, there's no increased systemic vascular resistance. They're not overloaded, so the amount of blood returning to the heart is normal. Normal venous return, normal heart function, normal output, normal perfusion to the rest of the body, normal perfusion of the kidneys, normal SVR. In a failing heart, which is a loose, floppy bag, doesn't have very good forward flow. And so what happens as you poorly perfuse the kidneys, angiotensin II goes up. And so the systemic vascular resistance increases, clamping down the afterload. This is increased systemic vascular resistance. And because there's not a lot of forward flow, blood is going to back up before the pump, and you're going to have volume overload. And so when you think someone is in a heart failure exacerbation, what you have to do is assess, is this exacerbation a product of increased systemic vascular resistance, increased volume overload, or both? And you're going to basically build a 2x2 table to help us understand which is which. You want to ask if the patient is warm or cold versus dry or wet. Where you want to be is here. They are warm and well perfused, and they're not volume overloaded. Warm and dry is a normal patient doing well who does not need to be admitted. The common patient that we see on an internal medicine floor service is going to be the patient who is warm but wet. This is simply volume overload. Wet and dry are assessments of volume. Warm and cold are assessments of systemic vascular resistance. It makes sense then that if a person comes in a little volume overloaded, and that's their only issue, they are truly warm and wet, the way you get them back to normal is by taking off the volume. That is, they improve with diuresis. What is more dangerous is when the patient is cold. That is to say that systemic vascular resistance is elevated. If they are cold and dry, it means they have no volume overload. They just don't have any forward flow to perfuse the kidneys well, and thus the response is an increased systemic vascular resistance. This person is in a low flow state. To get from cold to warm, you simply need to open up the peripheral vasculature. You do that by reducing afterload using vasodilators. That is the case whether they are warm or dry, because if they are cold and wet, they are in trouble. We call that cardiogenic shock. You can use vasodilators to try to get them from being cold to warm. But the thing that gets the patient who's cold and wet into a better state is going to be inotropes. And so hopefully you're able to see that the thing that will take someone from cold and wet to warm and dry is going to be a combination of diuresis, inotropic activity, and vasodilation. That is to say, we give support to cardiac output, we remove the afterload, and we help take the volume off. This can be done with the inodilators. Watch our shock lecture, Shock 2, about pressors. Inodilators like dobutamine and milrinone give both cardiac support as well as peripheral vasodilation, taking that person from cold and wet and bringing them more towards cold and dry. And you give additional diuresis because once you improve flow to the kidneys are going to start taking off that extra fluid and you can help out with diuresis. This is an oversimplification of the acute exacerbation of CHF, but is a framework to help you build what the next step is going to be. But before you can do that, let's talk about how you assess SVR and volume. The first thing is let's compare wet and dry. Wet and dry has to do with congestion and has to do with assessing the pulmonary capillary wedge pressure. Now, we are not cardiologists, so we're not going to be able to drop a swan in every patient. Instead, we're going to use the history and physical to attempt to determine are they wet or are they dry. Historical questions are going to be the things that we use to identify heart failure in the first place. Dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea, and weight gain. Don't forget about abdominal pain. Now we know this person already has heart failure, so the presence or absence of these things aren't very useful. We know they're going to have them. What you're looking for is an increase in severity. 2 weeks ago, the person could walk 3 blocks. Now they're dyspneic at rest. The person used to be able to sleep on 1 or 2 pillows. Now they're on 4 or 5. They've gained weight and they have abdominal pain. So you're looking for an increased severity of the 3 things that are going to be classically found in all heart failure patients, as well as weight gain and abdominal pain in their history. The physical exam to show congestion is going to show you 3 things: peripheral edema, jugular venous distension, and pulmonary crackles. Breaking it down for you, you're only going to get crackles if you have left ventricular dysfunction, JVD and peripheral edema, or right ventricular dysfunction. But of course, most patients present with symptomatology of both because they're long-standing heart failure, left-sided leads to right-sided. Peripheral edema, you're going to push on their shins or their ankles and let go, see how long it takes to recover. Jugular venous distension, you're going to attempt to identify where the patient's sitting. We'll talk about this in a bit. And crackles should be dependent. That is, they should go with gravity. And you can assess how high up their thorax the crackles are to get an idea of how much fluid is on their lungs. The presence and absence of JVD is actually a difficult concept. What you want to do is assess, do they have a ton of JVD or do they have very little? You're going to attempt to use the angle of the jaw and the collarbone as your marker. The question is, when you see jugular venous distension, in between, you can make an easy assessment. This is a classic physical examination tool. But what you don't know is if you don't see the top of the column, the question you have to ask is there so little venous pressure it's just not popping up over the collarbone? Or is there so much venous pressure that the top of the column of water is actually already in their skull such that you'll never see it? So this being extreme JVD, this being no JVD. the jugular venous pulsation is elevated so high in extreme JVD you can't see it, and the jugular venous pulsation is so low in no JVD that you can't see it. So how do you differentiate the two? Well, you have the patient start at 90 degrees, and you continually drop them down, performing the hepato or abdominal jugular reflex. At 90 degrees, you need to have the most pressure in order to show the jugular venous pulsation. If you drop them down from 60 to 30 to 0, it means that there is less pressure required to demonstrate a jugular venous pressure. So if they're upright, you see nothing. But when they're flat, you can see it. That means that the jugular venous pressure is actually quite low. If they're at 90 and you can't see it, and you can't see it as you progress to 0, it means that it started above the angle of the jaw. The hepatojugular reflex test is where you push on their belly, and the column should rise. This is where you usually see it if it's below the collarbone, and it will rise and dissipate. An abnormal test is when it rises and stays elevated. Both of these tests can be used to determine whether or not the jugular venous pulsation is below the collarbone or above the angle of the jaw. If you see the jugular venous pulsation, you're then able to measure in centimeters of water from that point to the apex of the heart and determine what the elevation is. My point being that the jugular venous distension is crucial in determining volume status. It has a very high likelihood ratio of both positive and negative, so that you often need to be able to identify the jugular venous pulsation. If you can't, that's fine, but you should go through extra steps in order to determine whether their jugular venous pulsation is below the clavicle or above the angle of the jaw. And you do that by performing multiple maneuvers at once. So to review, wet and dry is a difference of exacerbation of the typical symptoms of dyspnea on exertion, paroxysmal nocturnal dyspnea or orthopnea, weight gain, abdominal pain, and a physical exam that shows peripheral edema, JVD, and crackles. If they are wet, give them diuretics to make them dry. The other assessment you have to make is, are they warm or are they cold? This is about systemic vascular resistance. The history you're going to get is going to be a history of fatigue and decreased mentation. And this is something people miss a lot. You might see someone in the morning or 10 hours after they were in the emergency department attempting to be resuscitated by the ER before they got admitted. And you might meet this person late at night or very early in the morning after they haven't slept. And people will say, well, they were just a little somnolent because they were tired. No. It doesn't matter how tired someone is. They should be able to finish a sentence, have a conversation. So if what you get is this person who has persistent fatigue and couldn't go as far as they used to, and now can't really answer your questions or have a full conversation, that's a huge red flag for the inability of the left heart to perfuse the brain. Systemic vascular resistance is so high that it actually can't perfuse the brain well. The physical exam that's going to show you an increased systemic vascular resistance are things that we talked about in the shock lecture. If you have an elevated systemic vascular resistance, it is because the cardiac output had fallen. They're in heart failure, this makes sense. Their cardiac output is low, and the body is trying to increase systemic vascular resistance to maintain the blood pressure. We know from CHF1, this is backwards and hurts the heart. But the SVR will be up. So, peripheral vasoconstriction occurs such that blood is shunted away from the extremities and towards the core, which means you'll have cool extremities. But as we talked about in shock, it is not the fingers and toes which auto-regulate. It is the shins, ankles, and forearms that if they are cool, you're worried about them being cold. Also, as we talked about in the shock lecture, if SVR is up and cardiac output is down, diastolic tone is high and the vessels are clamped, the systolic whomp as very low. What you'll see is a narrow pulse pressure. That is, the systolic will be very close to the diastolic. This isn't normal, and it indicates that there's high diastolic tone from an elevated SVR and very little systolic WAMP. Diastolic tone of 100, systolic WAMP of 10. Other things like arresting tachycardia or pulsus alternans are also bad signs of the patient having increased systemic vascular resistance. Let's go back to our chart to try to explain what's happening. If you find someone who is cold and wet, you do not do diuresis to start, because the diuresis is only going to worsen GFR, worsening the systemic vascular resistance. The first thing you want to do is drop the afterload. The way you drop afterload is with ACE inhibitors. If they're in a hypertensive emergency and it's worsening their CHF symptoms, you can also drop them with the typical vasodilators, such as the calcium channel blockers like cardine, the beta blockers like esmolol, and the nitrous drugs like nitrous oxides. But in an acute CHF exacerbation, you do not want to compromise ejection fraction. So in an acute exacerbation, never give beta blockers. If the patient was on a beta blocker and faithfully taking it during their exacerbation, you can continue it. But if you give someone a beta blocker to drop their blood pressure, what you'll do instead is drop their cardiac output and kill them. The diuretics you're going to use are going to be furosemide and hydrochlorothiazide. Combining them has a more potent effect. The dose trial said that you can give furosemide up to 2.5 times their home PO dose as IV. That means someone who comes in on 40 milligrams PO BID can get up to 100 milligrams IV BID. And IV furosemide is about 2 times as potent as PO. These patients are overloaded. Their gut is edematous. Their absorption of medications is reduced. You can give them a ton of IV diuresis. What happens is they leave the unit faster. Their symptoms resolve faster. Their exacerbation ends faster. And you stop when their creatinine bumps, which happens faster. You cause an acute kidney injury in the hospital. But turns out 1 month later, they go back to normal. So when you see someone who needs diuresis, and they are not in cardiogenic shock, you've got them into the wet and warm area, then you give them a ton of diuresis, and you can hit them and hit them hard. For the person who is in cardiogenic shock, you want to start with either vasodilators, but they're in shock, so it'll drop their pressure more. What you instead want to do is give them the inodilators, dobutamine or milrinone. And if you are in this area, you probably should not be managing this yourself. This really goes to the ICU, and a CHF tertiary service should be consulted. But if you're in the unit and you're the one who's got this patient in the middle of the night, you want to be able to assess them as warm or cold, wet or dry, and know that if they're in cardiogenic shock, the treatment of choice is going to be the inodilators, dobutamine, and milrinone. I'm harping on this because if you don't know shock that well and you reach for Levophed, because that's what you usually give in hypotension because of all the septic patients you've seen, you will clamp down the SVR worse, you'll worsen the etiology of their heart failure, and you'll kill them. So, one more time, cold and wet, inodilators. Warm and wet, diuresis. Cold and dry, open up the peripheral vasculature with ACE inhibitors and vasodilators. Do not give beta blockers in an acute CHF exacerbation. That is CHF2, acute exacerbation. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.